Good morning, everybody. Welcome to Challenges and Approaches to Improving Understanding of Health Insurance Selection and Out-of-Pocket Costs. I have the pleasure to introduce Dr. Justin Cinder. He is the Leslie P. Schultz Professor of Risk and Insurance at Wisconsin School of Business at the University of Wisconsin-Madison. He's a leading expert on behavioral economics and health economics and a member of the National Bureau of Economics Healthcare Program. His research focuses on consumer choice in health insurance and incentive programs for healthy behavior change. And Dr. Cinder's work has been featured in numerous leading academic journals. And just a reminder to make sure that you are filling out those surveys and stuff after the program today. And I'll let Dr. Cinder take it away.
Great. All right, everybody here all right with the mic? Hey, well, thanks for being here today. I'm excited to get a chance to share with you, and then hopefully also have a good discussion. I'm very comfortable with questions throughout, though I know we've also kind of staged a 10-minute Q&A at the end where they'll bring the mics around and things. So hoping to also make this fairly interactive and get some ideas from you all, because I think what I want to talk about today are sort of the challenges and some of the approaches we have for helping people navigate health insurance options, and in particular, health insurance options when we're thinking about different levels of cost sharing they might be exposed to. So higher deductibles, higher out-of-pocket costs. How do we help people navigate the choices they have, and how do we help people navigate those plans if they're in them? And so I'm going to share some research, some of which I've done, some of which some other academics who sort of inhabit my same sphere have done. But some of this is also, I would say, very much kind of a work and challenge in progress. We have a couple of things that look a bit like answers, but a lot of what we have is sort of highlighting the challenge and maybe pointing to directions for further work going forward. And so some of you may already have some ideas or be kind of working on some of these things, and I'd be very interested to hear some of that. So the kind of jumping off point for what I want to talk about today, you can see in this graph, which is from the Kaiser Family Foundation. And what it shows is that the average deductible that people had in their employer-sponsored coverage. So these are people that we typically think of as having something of the gold standard of coverage. They've got an employer, they've got health insurance through their employer. The average deductible in 2006 was $584. But it's risen to this point to be over $1,600, far outpassing inflation. So we know over the course of the last 2 decades or so, people have become exposed to a lot more cost sharing. So less generous health insurance coverage and more decisions to make about health care and how it's going to affect out-of-pocket costs. Now, at the same time, in a lot of settings, people often have gotten a lot more choice that they have to navigate around their level of cost sharing. So the prior slide sort of says people are being exposed to higher deductibles. Underlying that, though, is that at a lot of companies, what you see is that the company offers people a decision. Do you want to stay with a more generous health insurance plan but pay higher premiums? Or do you want to take a plan that exposes you to a higher deductible, but will also save you a lot in premiums? So that trade-off has become fairly ubiquitous. Most employees are starting to have those sort of trade-offs. But we also see it in a range of other places. So people who have to make decisions for health insurance on the private market exchanges can choose between different tiers of coverage, from bronze up to gold, with very different out-of-pocket maximums and deductibles associated with those plans. We also see it in a range of other markets. So Medicare markets, a variety of sort of Medicare Advantage markets have different plan designs that people have to navigate. So on top of deciding things about what insurer and what network of hospitals do you want, there's this decision to make about financial things. And so what I want to talk about today a little bit is thinking a little bit about how well people can navigate those choices. Like, what do we know about the nature of the choices people make? And I've got this little cartoon figure here of a person sort of turning their back on a pile of cash on the table. And so a sort of preview to what I'm going to say here is largely that we now have mounting evidence that when you put people in these situations where they have to make decisions about their health insurance coverage level, there's a lot of cases in which it looks like people are making decisions that end up costing them extra money for the year. And so then I want to talk a little bit about, what do we know and, what have we thought about how we can help people navigate those choices. So, the first part of what I'm going to talk about, we've got some evidence about, people struggling to make choices in ways that make it look like there's some kind of fundamental confusions, maybe not surprisingly, with the financial features of health insurance, that's going to raise, I'm going to sort of mention that one thing that raises is a question about whether we should be offering choices, but also in a world where maybe that's a given, and maybe many of us who inhabit this space don't have the power to eliminate this kind of choice environment. How do we maybe make it easier for people to choose? But then the last piece of what I want to talk about is a kind of final part of once you help somebody choose and they navigate, some of what I'm going to reveal is that in a lot of settings, there's a pretty strong financial trade-off that's going to push towards choosing high deductible plans. So in terms of the total amount of money you're going to spend for the year, in a lot of settings, for instance, a lot of employees, but in a lot of other cases, this is also emerging in some other places, it's going to be cost effective in a just sort of financial aspect to choose to take on this higher cost sharing because the savings are going to be fairly big. But there is a question then of what happens once somebody's in one of these plans. And so I want to talk a little bit about some of the research that's been emerging over the last couple of years of how does cost sharing, how does being subject to a deductible and having to pay out of pocket for things affect whether or not people actually access and get care. And I think that's going to sort of round out a picture, and we'll talk a little bit as we go. So to kick us off, what I wanted to do is put you all in a choice environment that may look somewhat familiar. First, maybe before we do this example, how many people currently have health insurance at a place where you have to make one of these choices? You have to decide whether you want a higher deductible or a lower deductible. Okay, so most of the room has gone through this, so let's go ahead and simulate one of these. So this is actually from an employer-sponsored menu from a company that I work with. And so here what we see is they have 4 options. And at this particular employer, all of these health insurance options are offered through the same insurer, and they all have the same access and network to hospitals and doctors. So the only difference between them are these cost-sharing parameters. And what you can see is what I have on here is the annual premium. So that's the total amount you'd have to pay as an employee. This is the employee share of the annual premium. The company's also paying a large amount of the premium on the side in a way you don't see. But this is what's going to come out of your paycheck, withdrawn evenly in even installments, depending how often you get paid over the course of a year. And then you can see there's 4 different deductible levels: $1,000, $750, $500, or $250 deductibles. Co-insurance, the amount you have to pay once you hit the deductible, but before you've hit the maximum out-of-pocket, and then the maximum out-of-pocket limit. So you can see it's $3,500 in this plan, purple, goes down to $2,750 in plan black. Okay. So I'd like everybody to just think for a minute, if this were you, choosing for yourself, and for now, this is actually a single employee table. There'd be a slightly different one for families. I know many of you probably have families or spouses or others that you're covering. For now, just think about you. Suppose you had to choose health insurance that was going to cover you. Which plan would you select? Okay. All right. Everybody got one? Know what you're going to choose? Okay. How many people would choose plan purple? Okay. How many would choose plan blue? Okay, maybe 1 or 2. How many would choose plan red? Okay, how many would choose black? Okay, so what we can see in this room is we have kind of a uniform distribution. I would say by show of hands, slightly more people chose plan purple than any of the others, maybe less in blue, but somewhat uniform. There's a decent share in all of these plans. Okay, now, I don't want to ask any individual person for their specific reasons for choosing one thing or another. Those are going to be highly personal. But let's see if we can throw out just a couple of considerations that you all believe would come up for a typical person when they're considering this. So in particular, if we think about people who selected like plan red or plan black, why do we think they're selecting plan red or plan black? Like what are kind of dominant reasons? Anybody willing to throw something out? Yeah, way in the back. Okay, high utilization. And so I'll repeat, if we do answers here, I'll repeat them because we don't have the mics on people. So high utilization, right? So the typical thing you're gonna think about is if I know I need a lot of healthcare, I probably am gonna navigate this menu by saying, well, these are the plans that offer more coverage. They have lower deductibles, lower maximum out-of-pocket limits, so I'd probably navigate there, okay? How about on the upper end? So on the upper end, we might just go the reverse. We might say low utilization. Are there other reasons for on the upper end of why you'd choose it? Yeah. Okay, so the other sort of comment coming up here is health savings accounts or flexible savings accounts. In this particular case, this wouldn't be an HSA qualified one because the deductible's not quite large enough, but in general, choosing these sort of higher deductibles, there are also some savings vehicles. And so, some people like the idea of taking savings in premiums and then funding a savings account that can be used in some flexible ways for care. Yeah.
A way that I was figuring I would have a calculator out.
Uh-huh.
If I was planning on meeting my out-of-pocket maximum, adding that to the annual premium and see which way is the lower.
Yeah, and it's kind of tricky with these ugly numbers. This is like a trick for my sixth grader to try to get him to pay attention to his math. But did anybody kind of do this in their head, and did it lead to one direction? So where did it lead you as you were doing it?
I came up with a red, but it was very quick.
Okay, so kind of trying to do the math. So what this question was, or this sort of comment was about, is how another way of thinking about this is trying to think about the total amount of money you're going to spend for the year, the combination of what you're going to pay in your premium and your out-of-pocket costs. Now that's a hard thing to do because we don't know exactly what our out-of-pocket costs are going to be. But one nice approximation would be to say, well, suppose I was really worried about out-of-pocket costs. Say I'm going to have high utilization. Maybe I should just pay attention to these out-of-pocket maximums. And in fact, I think that's a really useful one in this menu, because if you do that, and if you had a calculator so that we didn't screw up the math, I screw up the math if I don't have a calculator. If you do that, what you're going to find actually is that Plan Purple has a lower total spending if you end up using a lot of care. So kind of paradoxically, it's kind of interesting. If it turned out that you were the sort of person who was going to need a ton of care, you were definitely going to need a surgery this year, or you're going to see a ton of specialists, and you're going to hit that maximum out-of-pocket limit. If you take that $3,500 and add $817 to it, you're at about $4,300. Okay? If you instead, let's just take Plan Black. Plan Black, this is just a bit under $2,000. You add that to $2,750, we're at about $4,700. So you're going to spend about $400 more with Plan Black, even though it's in theory the generous coverage, right? So the generous coverage plan costs so much more. In fact, this is an interesting menu to me as an economist because in this particular case, Plan Purple does what economists would call financially dominate. If you consider the total amount of money you would pay in the year with either through the course of premiums and out-of-pocket costs, there's no scenario in which you can pay more money with Plan Purple than the other plans. If you don't need any care, you save money because you just pay the premium. If you need a ton of care, you save money because the premium is bigger. And the best way to maybe see this is to notice if you compare this premium to any of the other premiums. So let's take Plan Red. Plan Red costs $600 more for sure for the year. Okay? So you pay for 100% sure, you're going to pay $600 more out of your paychecks. What does that get you? Well, it gets you potentially an additional $500 worth of coverage from the deductible if you need it, or $500 in terms of maximum out of pocket. So basically, if you use a bunch of care, you might save $500 with it. So if I compare Plan Purple and Plan Red, for sure I save at least $100, and potentially if I don't use any care, I save more like $600. So in terms of total spending, this happens, and if you do that same comparison with any of these, you'll find this. Okay. Now, most people, however, when they choose from these menus, do not do that sort of math. They don't do that kind of adding of the total out of pocket and the premium. Most people, we believe, sort largely based on utilization because that's sort of a natural heuristic to use. And in fact, we know this because we've studied this, both in employer-sponsored contexts. So that was data from a Fortune 500 company that offered all these plans to their employees. And we could actually see which employees choose what and how much money did they spend. And we've also then run this as experiments where we just ask people hypothetical scenarios like we did here today in different ways. And we see a very compelling pattern that's always true, that somewhere close to half the room, half the group of people, maybe 40 to 50%, choose that Plan Purple. And a lot of people choose the other plans. The Red plan, the second most generous in terms of cost sharing features, tends to be the second most popular. But the majority of people end up in one of these plans that will end up costing them more for sure for the year. And if we think about who does that, this graph shows you from the company where we studied this, the Fortune 500 company. On the x-axis, I have the salary of the employee in bins. We didn't know their exact salary for privacy reasons, but we knew roughly. And so these are in thousands of dollars. And so, and then we could see the fraction who chose a dominated option, meaning a fraction who chose one of these options. And what you can see is that at lower income ranges, it's pretty high. It's up in the 65 to 70% of employees select one of those plans that costs more in premiums, but ends up costing you more overall, despite the fact that it has lower cost sharing. And this falls as you get to higher incomes, but kind of interestingly, even among the highest income employees, okay, even among those making over $100,000 a year, we still see that 40% of them end up choosing one of these plans, okay? So, and then we further find when we look at this that there's the natural sorting you might expect. People with chronic diseases and people who are older are more likely to select these plans and not select these, okay? So what our research is sort of finding is that if you put people in a situation where you give them plan options, but you make the price differences so high, the premium difference is so high, that you're basically for sure going to pay more money if you choose the generous plan, even if you end up needing a lot of care, we see that a lot of people end up doing that, okay? Doing what economists would say, choosing a dominated option. Now, the question then is, okay, is this common? And if so, why? Why does that happen? The first answer to that is yes, it's actually increasingly common. So I've studied this with one of my graduate students, former graduate student, and what we did is we used data from the Kaiser Family Foundation. Every year they survey employers and ask them about the health benefits they offer. And in that survey, the employers report the features of their health plans and the premiums that employees have to pay, and also the premiums that the company pays. And there what we did is we looked at these cases where employers offered a true high deductible option, one that's eligible for a health savings account. And what we did is we made a comparison. We said, okay, if you took all of the savings that you get from the high deductible account through lower premiums and through any money, if the company does give you, to your health savings account, if you take those two things and then compare it to the potential savings you get with the other plan, the sort of non-high deductible plan through lower cost sharing, what we find is that at half the companies that are offering a high deductible plan, we have a scenario like what I showed you on the prior page, where the high deductible plan essentially dominates. There's no health realization where you would spend less for the year by choosing the lower deductible option. Okay, so this is about half of big companies that are offering these, you're starting to see this happen. I work for the University of Wisconsin system, as maybe a couple of you do. This is also basically true in the University of Wisconsin healthcare system. So the high deductible health plan is dominant in the state employee fund for the university. And I can tell you 15% of all enrollees are in that plan. 85% are in the other plans. Now, the first question, there's a why does it happen? Like, why do people enroll? But I think the deeper question you might have right now is, why does it happen, right? Like, why would we give people options and, some of them are gonna cost you more for sure, okay? Well, I think it's fairly natural when we think about how we chose, right? Most of us look at a menu and we say, okay, well, which one of these is probably right for me is probably based on my health utilization. Why else would you give me a bunch of choices? And I think there's this implicit assumption that probably all the options are roughly reasonable, so I can just kind of select which one makes sense based on my health needs. But what we're seeing is that that's not necessarily true, that there are some big cost differentials between plans. And when we look at the employer-sponsored space, what we find is that sometimes companies are trying to promote the high deductible option. So what we see is that companies, for a variety of reasons, believe they want to transition people to high deductibles, so they give really big inducements, really big payments to do that. But that's not probably the most important thing. The most important thing is this, and this is actually, I think, important because it suggests there's a general consequence and challenge when you start trying to offer choice to people, okay? And the big issue is that when we start offering choice, there's a natural tendency to sort, right? So if I give options with low premiums but not as much coverage, the natural thing is that our healthiest people are going to look at those and say, yeah, that's kind of a risk or something I'm comfortable with. And the natural thing is that those of us who need a lot more healthcare are going to look and say, no, I want the thing that covers most of my healthcare costs. But as soon as we start sorting that way, we lose our pooling, right? We no longer have our mix of healthier and less healthy types together. We start separating them into different plans. Then the question is, what's the consequence of that separating? Well, in an environment without regulation to prevent it, the natural thing is that the price that gets paid for the plan comes to reflect who's enrolling in the plan. So what's going on, I think, at a lot of the employer-sponsored settings is they're offering choices. People are enrolling in different plans. And what you're starting to see is that high deductible plans are essentially the healthier, younger worker plans. And they have low prices that reflect that younger worker pool. And the options that have more coverage are the sort of sicker, older employee pool and have prices that reflect that. And those big price differentials between those groups tend to drive such a big cost differential that even if you were one of those older people who has a lot of healthcare needs, you'd be better off financially at least joining the pool of the young healthies and taking their low costs and potentially setting aside that money to pay for out-of-pocket costs. Okay? So at least at a sort of high level, that's kind of Damon's story, that as soon as we start offering choices, we start losing our risk pooling benefits. Now, what can we do about this? I really think there's kind of two things that we've thought of and that our research thinks about. The first is we can question, as sort of a matter of policy, whether we should be offering choices of health insurance levels. Okay? And this is, I think, a tricky thing for policy, that there's a natural tendency to want to give people choice and want to respect their sort of financial decisions. But there's a kind of fundamental challenge in health insurance markets with the economics of it, that as soon as you start creating these choices, you start getting a breakdown in risk pooling. You don't have everybody enrolling in plans. You start having a tension where you've got healthier people in one plan and people with higher healthcare needs in another plan. Once you get that, then there's a question of, okay, how do you reconcile the fact that the different plans have different groups of people? And in some markets, we have regulations to force a kind of sharing of the costs across plans. So in the Affordable Care Act exchanges, there's some regulations that keep this from happening quite so much. There's no such regulation for employer-sponsored care. So in employer-sponsored settings, when employers start offering choices, they start creating a dilemma between their healthier and less healthy employees, okay? And so there's, I think, a big question of whether a movement towards choice is really a good idea or healthy within health insurance markets. Now, I can't solve that problem, though. And so what I have been working a little bit on is the question of, okay, suppose we're going to put people in environments like this where there are choices. Can we do a better job of making it easier for people to make these comparisons? So the sort of math we were hearing before of like, well, what if I compare this? We all know intuitively, and research shows, that that process is not easy for people or intuitive. Most people, when they compare options, if we go back to our table here, most people comparing these options compare options by scanning down columns. So we have eye tracking studies that have found people tend to look at this. They try to compare deductibles. The problem is that if you really want to compare a financial contract, you've got to sort of do some integration across. You have to think about things like, well, what if I combine this cost with that cost? So what I've been working on a little bit is how do we maybe make that a little easier for people? How do we potentially improve on that dimension? And so I want to tell you a little bit of what we've been doing here. So I've been researching this. This is also something that there is a large landscape out there of people trying to do this. And some of you may be engaged in this. And there are some like small rule of thumb type things that we try to give people, like these tricks about adding premiums and maximum out-of-pockets. And in a number of settings, you'll see this in the Affordable Care Act exchanges. There's a sort of a health cost expected cost calculator embedded within the Choice platform on healthcare.gov. Many employers, if you enrolled, you may have had some sort of little health decision tool. How many people had some sort of decision tool when they enrolled? Okay. How many people are like, we might have had one, but I probably didn't use it? So that I think is really the dominant thing, is that there's some burgeoning interest in having these decision aids, but part of the question is, how do we give a decision aid that isn't itself hugely complicated or hugely burdensome, and how do we embed it, okay? So I haven't solved all those problems, so I don't have like the miracle solution to how do we get this in front of everybody. But I will show you at least our approach for trying to make this clearer so you kind of have a sense of the sort of direction we're going. So what we do is we take an approach where we say, okay, the key thing to trying to help you understand your health insurance options is that what we want to do is show you the consequences you have with the health insurance plan. Now, the challenge of that is that you don't have just one consequence. I can't give you a single number. If you choose plan A over plan B, there's a range of amount of money you're going to spend in those two different options. Right? Plan A, you could spend a little bit or a lot, going to depend on your healthcare needs this year, and nobody's got a perfect crystal ball. Similar plan B. So what ideally we want to help people do is make comparisons across all the ranges of spending needs they might end up having. So if you have a year where you end up needing a surgery, how do these plans compare? And if you have a year where you don't have much healthcare costs, how do these compare? Now, the other thing is that to give a good decision aid, we need to respect that different people are in very different situations, right? So I say, it could be a high spending year or a low spending year, but what's a high spending year or a low spending year for you may be very different than what it is for me. And so our approach to doing this has been to first try to find out the minimum information we can get from people to be informative about the types of health spending years they might have. Okay, and the way we approach this in our study, and you could do more with this if you had access to more data, but we tried to keep it as easy as possible, is we ask people a couple of very basic questions about their health status. So we ask them, what is your age? What is your gender? And what is your self-reported health status? If you had to compare to other people your age, how do you rate? And then we give them choices: excellent, very good, good, fair, and poor. Now, why did we do that combination? Well, there's a national survey, the Medical Expenditure Panel Survey, that has data on health spending for people each year, a representative population, part of the population, and it asks people all of those three questions. So what we can do is, once I know how you answer those questions, I can look at the MEPS data and I can say, okay, for people who answered those questions like you, here's the distribution, here's the range of health spending needs. So some of them had big surgeries and needed a lot of health expenditures. Some of them had less. If you answer those questions, if you're older and you say you're in poor condition, most of the people in the MEPS who answered that way had high spending, but they didn't all have exactly the same high spending. If you answer and say that you're very young and very healthy, most of the people had very little spending, but there's a small tail of people who got into a car accident or a bike accident or something that year. So we ask that question. We use historical data then on healthcare spending for people like you. We run those spending needs then through a health insurance plan design. We basically say, okay, for each of those people in the Medical Expenditure Panel Survey that we could compare for you, how much would they have paid out of pocket this year if they had had plan A that we're considering for you, or if they had had plan B? So we run the calculation and then we add the premium onto it. And then what we do is we create a graphical illustration of the amount of money you'd spend in a way that we hope lets us compare plans. So let me show you what these kind of graphs look like, and then I'll show you what it looks like for the menu we considered at the start, okay? So here's a menu of, so here's the way we designed this. So on the y-axis, we show people their total health spending for the year, and we coach people and tell them that's your premium plus your out-of-pocket costs. And what we have on the x-axis are possible spending groups you might end up into. So what we tell people is, for all the people who answered the survey like you, we divide them into the group with the lowest 10% of spending, the next 10% of spending, all the way up to the top 10% of spending. So you can think of this as you have roughly an equal chance of landing in any spot on this graph. And this would represent the 10% best times for you, and this would represent the 10% highest spending for you. And then what we're graphing is the average spending people have from that group on this line. So this line gives a representation of the possible spending levels. So this particular example is for a young adult who's healthy, okay, a healthy young adult, getting this contract purple that we talked about before when we were looking at the menu. And so what you see is for a young adult like that, for the first roughly 40% of cases, so the bottom 40% of cases, they're not going to go to a doctor and they're just going to pay the premium. The other 60% though are going to have some medical bills, and you can see this line rises as they pay more and more out of pocket and they pay some under that $1,000 deductible. Up to the highest group on average spends a little more than $3,000. Okay. Now, here's what the choices look like, and this comes from an experiment we ran where we showed this graph to young adults making choices at the university from that same menu, hypothetically, that I showed you at the beginning. And so when we plot those 4 options you saw before, Plan Purple, remember I said, was dominant. When you look at it graphically, what you can see is that for every spending group, Plan Purple has a lower total spending, regardless of whether you end up in the high spending groups or the low. Now the gap is bigger if you're having one of these better years, and it narrows as you get higher, but it doesn't cross. Now, what we find is when we show people this sort of menu, it dramatically changes what they say they would choose. So the gray bars, if you remember, were how people chose when I just showed them a table, like what we had in this room here. The blue bars show you what happens when I show people instead that graph. And what we see is over 90% of people say that they would select that dominant Plan Purple. Now this is among the young adults. I want to come back to that in a second. But among the young adults at least, this dramatically changes what they think they would choose. Okay? So this is kind of a proof or a demonstration that if you show people these kind of graphical formats, it can have a big impact on what they think they would want in a health plan. And we've done a bunch of additional studies testing this with other menus where we don't have exactly dominant options, and with a broader set of population, older folks, people with more health needs. And we find the same thing, that if you show them these graphical representations that make it easier to compare options across a range of scenarios, from good years to bad years, you get a pretty big shift in choice patterns, often in the direction of people being willing, given prevailing prices, to take higher deductibles and plans that look like they have less coverage, because I think the benefits of the cost savings become much more salient. All right, so that's kind of the basic thing. So there's sort of a power and a limit to what we're finding with decision aids. The good part is that decision aids seem to greatly simplify this type of decision aid, the choice process. We found, for instance, when we did these studies with undergraduate students, that when we did a measure of insurance literacy, basically we tested, could you make a calculation of what your out-of-pocket costs would be if I told you a total amount of bills and I told you deductibles and coinsurance? Could you do that math? You know, not surprisingly, about 50 or 60% of undergrads, even at the University of Wisconsin, can't do that math, right? That's not easy math. And there's a clear choice differential. The people who are better at doing that math are more likely to choose these dominant, financially dominant options. When we give the decision aid, that gap largely is eliminated. So people who can't do that math can nonetheless process that graph pretty well. Now, of course, that's in an environment with people who are relatively graph literate and with some coaching and some instructions. That won't always just hold if I just plop this graph down in front of somebody without a little coaching. It's not clear how well it'll go. That's still research in progress. A challenge we see, though, in real-world environments is that engagements with decision aids in many settings are very low. And I think there's kind of maybe 3 dominant reasons for that. One is that they're often really poor choice design. Okay? So the details really matter of the choice environments you put people into. And in our studies, what we're showing is if I put you in an environment where you have to look at the decision aid, it has a big impact on what you would choose. But in many environments, we don't naturally embed decision aids in the choice environment. People have to seek them out, or they have to do a bunch of extra steps, and they decide it's not worth it. So one of the, probably the next, like the last mile challenge here is figuring out how to embed these things naturally into choice platforms and choice environments. The other issue, though, that we're seeing is that people do not trust a lot of decision aids, and I think part of why they don't trust them is that they don't fundamentally understand what's happening in the background. So in particular, what we found is we also tested for that same sort of experiment we were running. We tested our kind of graph that tries to show you all these scenarios and tells you we're taking people like you from a survey and comparing to what would happen if we instead just calculated your expected spending in every plan, which is a very typical thing. That's, for instance, what healthcare.gov does for people choosing marketplace plans. And what we found is if we just give the expected values, it has only about half the impact on choice patterns. And one of our interpretations of that is that when people see an expected value, they don't fully trust it. They sort of say, well, you're trying to point me in one direction, but I also know insurance can cost different amounts. I'm worried about the risk here, and you're not really clarifying the risk. Or what we found in surveys of people at the University of Wisconsin, they have a tool called ALEX that gives you some scenarios and lets you choose a scenario, one scenario, and tells you what plan would be better for you. And people report, and this is a dominant case, ALEX always tells them to choose the high deductible plan. And people report and complain, they're like, no matter what I put in, ALEX keeps telling me to choose the high deductible plan. I don't trust this thing. So there is this challenge that people don't necessarily believe what these tools are showing them. One of the things I think this points to is that one of the places that might be most valuable for decision tools is not so much for the end user, but for the menu designer. So if we think, for instance, at employees, or if we think about sort of the insurance companies to the extent that they're sort of positively engaged with this process, or if we think about the benefit consultants and others, helping them visualize what are the consequences of choosing different plans to different people in a more salient way could be helpful. But the last thing I wanted to talk about here, sort of the bigger problem, just kind of checking my time here, make sure we leave enough. The bigger problem is that there's sort of a bad catch-22 emerging in this ecosystem of health insurance choices. So what I've talked to you so far, I've argued, okay, we're often entering this environment where we make choices. And when we make choices, you get these big cost differentials between high deductible and non-high deductible health plans. Okay? So, and that often seems to come from the healthier people sorting into the plans without a lot of cost sharing, driving a big wedge in the prices between these plans. So that exists, that's happening in the world. And so that may suggest that, well, you're gonna lose money for sure if you don't choose the high deductible. So to some extent, if you're a person with high healthcare needs, the financially logical thing is to say, all right, I'll go join the healthy folks, I'll save all this money on premium, and I won't be financially worse off. Okay, so that's what the sort of stuff says. But here's the problem. What's cost effective might not end up being health effective. And I think the problem we're starting to see with the health effects are that there's a number of studies that have come out and have started to look, okay, what happens when people have these cost sharing? What happens when they have to pay out of pocket? Okay? Now, in theory, we would think, well, financially, with all that I showed you still holds and is true. Financially, if you hold fixed your health spending, if you go to a doctor just as much as you'd need, you'd save money choosing that high deductible plan, save the premium. At the end of the year, you'll save money. The problem is that you very well might not go to the doctor in the same way, and you might not fill your prescriptions the same way, because now you have this kind of pain of paying, or this direct cost. Now, if you're enough of a kind of health economist type, you might say, well, you're making that sound like a bad thing. That's the whole point of the high deductible plans. So health economists pushed high deductible plans back in like the 1990s and early 2000s, in part because the idea was, well, if people were paying out of pocket, they would pay attention to the cost of things, and they would then only do the healthcare that's really cost and beneficial for them, and we could save costs in the whole system. Okay? So the idea that people might not do as much healthcare when they had high healthcare costs was sort of part of the original rationale. But the challenge of what we're finding, there's been a couple of studies, and I want to highlight two. One of them is from a group led by Brock Goldberg et al. I'm not part of this research group, but they did a really influential study called What Does a Deductible Do? The Impact of Cost Sharing. And what they studied was they studied a company where the company did what in theory would be kind of sensible and reasonable for their employees. They switched everybody to a high deductible plan. And at first you're like, well, okay, so the company's just saving a ton of money. They're putting it all on the employees. But at the same time, they gave the employees a really large amount of money, $3,000 a year, into a health savings account. So in theory, the company set up an environment where the employees shouldn't be worse off. They're getting the money that they would need to pay for their out-of-pocket costs, but now they have the freedom to make those choices. Well, what these researchers did is they got access to the information. They saw, okay, well, what really happened when somebody went into these high deductible plans? And this graph sort of shows the way that this is the dollars of spending, okay, for different groups of employees. And what you can first see, this gray line shows the year when they made the switch to high deductible. And what you see is for all the employees, there was a pretty sizable drop of 12 to 20% in healthcare spending. So there was a big reduction in healthcare spending, and this is one reason that an employer might want to sort of push for this option. You get this big reduction. But when you look at this, there was something kind of puzzling to them, that in particular, this top line, this is the top quartile. These are people that typically had chronic healthcare conditions, okay? So these folks, in theory, what we should expect to see is you're going to likely hit your maximum out of pocket, and they gave a bunch of money to the health savings account. In theory, these should be people who should be planning for their healthcare costs, and for whom doing this should not lead to a big change. If you were going to kind of guess ahead of time where you might see change of, like, you know, things that maybe could be done but maybe shouldn't, a lot of people might have expected it to be kind of in this range, but not in the really chronic. But what you see is actually a really massive reduction for the chronic folks. And they dug deeper. And what they found was that if you isolated into healthcare categories where we would hope that people would not cut back when they have cost sharing, you see big cutbacks. So 12% reduction in preventative care visits for people with a prior diagnosis, 48% reduction in fills of diabetes drugs, 18% reduction in antidepressants, 24% reduction in hypertension drugs, 20% reduction in statins. These are all categories that, you know, it's hard to argue that there was a lot of wasteful care in those categories, right? Now, they also saw reductions in things that maybe they're trying to target, like, you know, imaging for diffuse lower back pain, right? Like, that's the one everybody likes to talk about. You don't want to go get the MRI for that. They saw that reduction, but they also saw reductions in all of these things. Okay. There's also a study in the last year that some of you might have heard of that's been very influential in, I think, some of our thinking around this, that studied seniors on Medicare plans and looked at their drug spending. And what they found, they had a group of people that get subsidized copays for their drug plans, and they could compare those people to people who had a full subsidy, so who didn't have to pay any out of pocket for drug plans. So these are sort of very low income seniors. And at first, this is a histogram showing the amount of out of pocket spending per script, like so per prescription fill. And when economists in particular look at this, what we see is, okay, well, the vast majority of these payments are around $5 or less. So what we should be thinking about is these are seniors who, when they go to the pharmacy and have to fill their prescription, that cost is about $5 or less, maybe $2. And so the default sort of thinking for many economists and others would be, all right, well, if somebody has a routine drug need that they know they need, and you're talking about $5 or $2, that's probably something people can budget for and can handle. But what this research group looked at is they said, well, maybe we can figure this out a little bit. And what they exploited was the fact that for people who are mostly living off their Social Security payments, there's a sort of randomness in when exactly you receive your Social Security payment. So depending on your birth date, you might receive your Social Security payment on like the 2nd and 4th week of the month, or you might receive it on like the 1st and 3rd week of the month, okay? And so what they did then is they knew people's birth dates, and they had the Medicare data to see when people were filing prescriptions. And so what they did is they looked to see what happened around people's pay dates, okay? And what they were calling this was liquidity sensitivity. So their interest was, do people wait to fill prescriptions for when they're going to receive their paycheck, their Social Security check, or do they fill prescriptions sort of as they're needed when they come, okay? And this is a graph of their kind of main finding. On the x-axis here, they have the days since the person received their check. So 0 here is the day that you get your check, okay, in the mail. And that's kind of random. It depends when you are. So it's not something special about you. So they've got grouped in a bunch of people here. And then these are days before and days after the check. And what we have is 2 series here. The folks in red are the people who had to pay those what are seemingly modest copays of $2 to $5 in the subsidized copay group. And the blue is the folks who had no copay. What you see, great, what you see here is that among those who didn't have to pay copays, if you could go to the pharmacy and get your prescription when you were ready to fill it, there's no spike on payday. So this rules out the possibility that maybe most seniors just revolve their lives around when they get their Social Security check and they do all their shopping that day. That's sort of leading kind of economistic explanation for what I'm about to tell you. What you see is for that group, they are no more likely to fill a prescription on the day that they get their Social Security check than any other day. They seem to go to the pharmacy when they need a refill. Okay? This is also true, importantly, for brand new prescriptions. So when they get prescribed a new prescription and they fill it for the first time, it appears they just go to the pharmacy and get it whenever they get that prescription. Here are the folks who have to pay $2 to $5 for their prescription fills. They are significantly more likely, almost 15% more likely to fill a prescription on the exact day they get their Social Security check than other days. So that's pretty strong evidence that these seniors are waiting for their Social Security check to fill their prescriptions. And as they delved into this and looked at it more, what they found is that for a range of prescription categories where we might worry about people going for a while without filling their prescription, where it's the sort of thing you don't really want people delaying, you see this same sort of pattern, that the people who have to pay these copays are sensitive to it. So I want to summarize here, and then we can open for some discussion. What we're finding in the research is first that plan choices have some big financial consequences, and it's not the case for a lot of people in a lot of settings that it doesn't really matter which healthcare plan you choose. The financial consequences of choosing different healthcare plans can be sizable. So in a lot of these places where I was talking about there being dominant options, we're talking about $500 to $1,000 a year in expected savings by choosing the kind of more cost-effective plan. Okay? And it does look like we can do some approaches to help people navigate that. So if we show people these kind of graphical interfaces and make the comparisons do the math for them, they seem responsive to that. There's a big challenge. We have to figure out how to make that easy and how to get it in front of people, but it's a challenge we might approach. But we're running into this catch-22 at the same time, that it's financially valuable for people to select into these high cost sharings because they need to not, so if you're a higher healthcare cost person, an older person, choosing into a plan in a lot of environments that separates you from the younger, healthier folks is going to cost you a lot of money. But to stay with them, you have to be willing to join and take on these high deductibles, and then you have to navigate your out-of-pocket costs. And from two different settings now, we have some evidence suggesting that when people have to do those trade-offs, it's a hard thing to do, and so a lot of people just don't do it. And I think there's probably two things. One, thinking about the costs is painful, and so I might just decide to suffer a little bit and not deal with this financial stuff. And two, budgeting is hard for a lot of people. So even if over the course of the year you're gonna save money in one plan, to navigate that well, you actually have to set that money aside in a place that you're gonna use it for out-of-pocket costs, and you have to think about that budgeting. And that's sort of where I think I kind of end up here, is that I think the next wave for some of this research, but probably even more importantly for a lot of the practice of people who are, sort of on the ground working on health literacy things, is trying to think about if we're in an environment where there's some really strong pressures pushing people towards needing to navigate health insurance that has higher cost sharing, we need to really be investing in ways of helping people anticipate and budget and set aside the money for that, and giving them mental frameworks for how to not think of every doctor's visit and every prescription as being this painful cost, but think of that instead as something that you already have financed. So, historically, if your insurance is covering it, you don't let the financial aspect be the kind of driver of whether you fill your diabetes drug, and we can see that among the seniors. But as soon as there's this kind of trade-off of $10, we're putting people into a real tricky trade-off of finances and health. And so finding ways of helping people budget and allocate budget towards those costs in this environment with high health costs is, I think, kind of the next frontier. And unfortunately today, I wish I could come and show you the graph. It's like, we've nailed this. We know how to help people budget. That's a way harder problem, as many of you know, than helping people choose in the moment. And so I do think that's the next frontier. It's also the reason why I personally am not on a huge crusade yet to try to get everyone to choose the high deductible plan, because I do think we're in a little bit of a catch-22 situation where I think the people who aren't in a good position to choose that plan are losing out some. There's better benefits to people who are either inherently healthy or financially savvy in a way that they can take on these high deductible plans in our current environments. But there's a lot of people for whom this really is a difficult challenge. You can either spend more for sure, but navigate your health maybe a little more efficiently, or you can spend less, but there's a chance you're not gonna be able to navigate so well. And I think that's kind of the key challenge. All right, so let me stop there, and I'm very happy to open it up for questions or suggestions, or if people have seen, effective approaches on any of this stuff, I'd be very interested to hear.
Hello. I just have a couple comments,
Yeah.
actually. So what you were talking about really is financial literacy meeting healthcare literacy.
Yep.
My husband works in the financial realm, and he's extremely passionate about financial literacy. They have I just feel like there's an opportunity for healthcare literacy to partner with
Yeah.
financial literacy groups.
Yeah.
And come in and help with that. On the other side, also, just an idea, when presenting healthcare options, very similar to everyone maybe has a credit card.
Many of us have credit cards.
Yeah, many people do have credit cards, right? Some people don't, they choose not to. But when you have a credit card, when your credit card statement comes, it states exactly how much, if you were to pay this
Yep.
down over 12 months, this is how much you're going to be paying total based on your interest rate,
Yep.
right? So in healthcare, if you just, like that little box that you have, right, your table, if you just had that one extra table and you said, okay, we're gonna do the math for you, similar to what you were talking about, right?
Yep.
You're like, well, we did the math for them, but then making it more of a conversation.
Yep.
Right, so
Yep.
we did the math for you, this is how it's calculated, this is why it matters to you,
Yep.
having the conversation, so, thank you.
Great, thank you. So I guess we're gonna pass this here and then come back around that way.
Okay. So as far as HSAs,
Yeah.
when you have a high deductible plan and you come in with a copayment starting right from day one,
Yep.
does that affect the HSA?
So by affect, what do you mean by affecting the HSA? Like, does it end up affecting how much you get put into the HSA?
As far as
or-
whether you can put money in. So I'm a navigator for the
Yep.
marketplace,
Yep.
and lots of times I will see a high deductible plan, but it
Yep.
says that you cannot go and have an HSA.
Mm.
And so I'm trying to understand that, and I don't
But
know if
why is that?
co-payments
Yeah.
are,
Yeah, so that's a great question. So a few other people in the room may know this policy even a little better than I do. So I'll tell you my understanding of it. And so the problem as we see it is that there are plans in the, like the ACA space in particular, that have really high deductibles, high enough that they should qualify for HSAs, which are these sort of federally sponsored tax savings vehicles where you can set aside money for paying out-of-pocket costs. They have some nice tax properties, and in general, they're sort of set up to help people do this budgeting to pay. The issue is that the federal regulations for what you have to be a qualifying plan for a high deductible were such that they were set up, that they were designed because they were motivated by this old health economist thing that said, well, we want people to have their financial stakes on the line so that they make these decisions. The original regulations said you couldn't qualify for an HSA unless you basically had to pay everything until you hit the deductible. So in the ACA, though, a lot of insurers are experimenting and realizing, oh, people struggle with hitting these deductibles, right? They won't go to the doctor, so we're trying to add more outpatient stuff under copays because we know people do want to go see their specialist, they do want to do things, so let's make that a $10 copay, but for a range of other things, we're still going to hold premiums down by having high deductibles. When they do that design, though, it invalidates their access to the HSA. There are debates and sort of pushes into Congress and other ways to try to make more of a balance here, try to make more of this sort of cost sharing with, carving out things like all the stuff that we think we don't want people pulling back on. Let's find a way to make all that stuff covered and still allow people to set money aside to budget for the other stuff. But that it hasn't all fully happened yet. So my guess is in the next couple of years, There will be some tweaks, and more of those ACA plans will be eligible for HSAs, but a lot of them still aren't.
That's good, because you figured, you know, like you were talking about specialists, so you spend $50, but that doesn't include all the tests and everything.
Yep.
So a patient may be going in saying, okay, I'm seeing you, but no, don't do
Yep.
anything more, because I have another 6,000 to go.
And that's one of the interpretations also for why we see these big health spending effects, is that I think a lot of people rationally know, well, look, I could go to this doctor's visit, and if I go to a doctor's visit, maybe I have a rough ballpark of what the doctor's visit is going to cost me. Maybe it's going to cost me a couple $100, and I do have my HSA money. Okay, I could cover that. But if I go, it's going to start this snowball, and I'm going to have to decide whether to do all the things the doctor tells me to do. Should I get all the tests, or do I have this awkward conversation with the doctor where I say, yeah, no, I'm not going to do the MRI. It's a little too costly. And so anticipating all of that, maybe I just don't go at all. And so, you know, I think that also raises this challenge that as we get more cost sharing stuff, we also need to have an improved environment for helping people know what things are going to cost and how to plan for them. And we're way behind on that for a whole bunch of other complicated economic reasons.
Thank you.
I had one more question, then I will pass it on. I think it's a simple yes
Sure.
or no.
Yeah.
You were talking about the simulation where you took information and you put it into a health plan design.
Yep.
Was that created by you?
Yeah, we did that. So we kind of
Okay.
created like a little computer program that would essentially say, here's your deductible, here's your other things, and I know what you paid. There are some commercial vendors who are starting to do that in a more sophisticated way than we could do as researchers. So there are a couple of places that like employers are now starting to contract with, and some of the like Medicare exchanges are starting to contract with some of these firms that do this in a really fancy way, where they figure out exactly the distribution of possibilities for somebody like you, given your history, and then they run it through all the fine details of like the co-payments and everything else, which get very complicated very fast. But they, yeah. Yeah, exactly. Yep.
Hi. From an economic perspective, are there ever any instances where if somebody, you talk about that like liquidity issue, where it would make sense to pay a little bit more in premium so that if they have an accident, they suddenly are hit with,
Yep.
you know, a $5,000 bill, and if they were paying, you know, a little bit more in premium every time, they wouldn't necessarily have that gigantic payment all at once. Is there ever an instance where it might make sense to do it in that way?
Yeah. So it's a great question. In fact, I have a paper where we've been trying to do those calculations, and the short answer is yes. That essentially, for instance, if you live in a very hand-to-mouth sort of way, where you really can't borrow very effectively. You don't have access of easy ways of smoothing out your payments, or maybe you do, but like the way you're going to have to borrow is through payday loans at 400 or 500% APR sort of rates. If you're in that sort of environment, in a lot of these cases where we say something is financially dominant for the year, it still would be a better choice for you probably to pay that extra money, since you can pay the paychecks throughout the year. The way we really think about that, though, is in some sense, it's highlighting yet another cost of being liquidity constrained and not having that slack, because it sort of highlights that if there were some way of, and this gets back to the financial literacy point, if there were some way of planning differently and setting aside a little bit of buffer so that you could then take that high deductible plan, it would have big returns. Yep. But yeah, it is in a very, we sometimes talk in sort of behavioral economics about sort of bounded rationality. It's like taking as given the situation and the way your life lives out, is this a reasonable thing to do? And I would say yes for many people. And that's another reason why I don't sort of get on a big soapbox and tell everybody you have to choose the high deductible plan. If you're somebody like me and you have sort of a high income and finances are fine, I do make that recommendation. So I get on my soapbox with my colleagues and a few other people, but not as a general way. Yep.
Thank you so much for your time. We're right at the time at 11:45. We're going to have a break for lunch. Thank you. This has been wonderful information, and if you stick around for a few minutes for any extra questions. Otherwise, thank you everyone for attending. Take some time to complete the evaluation and go enjoy your lunch, and then we'll have our next sessions at 1 o'clock.